Hello, my name is Ehud Asya, and I would like to present a case which I termed "It Ain't Over Till It's Over." When we operate a case with a very advanced and hard cataract, we often have this dilemma of what surgical approach should we utilize. Is phacoemulsification the best technique for such a hard lens? And to date also, should we use the femtosecond laser, as it can help perform a perfect anterior capsulotomy and fragment the lens nucleus and save energy? So this is a case of a patient with a very hard +5 cataract in which we utilize femtosecond laser. After removal of the lens anterior capsule, we can see the laser marks over the lens material. However, it barely scratched the surface of the lens. Practically, it did nothing, and it did not fragment the lens material. So now we perform a routine phacosurgery. However, we need to use a lot of phaco energy in order to break and to remove this entire lens. A generous amount of dispersive OVD is repeatedly injected to protect the corneal endothelium, and now we perform phaco, phaco, and phaco. At this point, I'm asking myself, did I choose the right surgical technique? There are alternatives. If I only created a large scleral tunnel, I could probably remove the entire lens as one piece and make surgery much easier and much faster. The wound can be closed with 1 or 2 stitches, and oftentimes even left stitchless. However, I prefer to do phaco, so now I continue and do phaco and phaco and phaco until all the lens material is removed. Just to find out, there is a wide tear in the posterior capsule, which is an extension of a tear in the anterior lens capsule. Apparently, there is enough capsule to support a posterior chamber IOL, so I implanted a 3-piece IOL to the sulcus. However, the trailing haptic did not come out. It was stuck in between the cartridge and the plunger. I tried to release the optic, but eventually it detached from the IOL optic. Now, to release the optic, I cut along the plastic cartridge, and that's what I should probably have done before I pulled out the injector. When the optic is released, it seems intact. The optic is intact and the optic is intact, so I tried to re-engage the optic and the optic to reform a 3-piece lens. And it worked. Now I need to insert the lens optic behind the iris into the sulcus. I did very carefully so it will not disengage again. Eventually, the IOL was in the sulcus, central, and apparently stable. At the end of surgery, the optic is in position and the lens is well centered. This is the eye at 1 week post-operatively, and this is at 1 month. The optic is in its proper position, just like new. Uncorrected visual acuity was 6.5 and corrected vision 6.6 with 2.5 diopters of against the rule astigmatism. Now it's the end of the case, and at last it's all over. Thank you very much for your very kind attention.